Good morning, everyone. I am Dr. M.I. Shuja, lecturer in pharmacology. Today's lecture topic is pharmacodynamics. So far, we have been seeing what the body is doing to the drug, that is pharmacokinetics. We have seen the basic four action: ADME, absorption, distribution, metabolism, and elimination. And we have looked into few concepts like bioavailability, plasma protein binding, stress fast metabolism, etc. Today we are going to see what the drug is going to the body. That means what is the mechanism of action of the drug, how the drug is performing that particular mechanism of action. So, pharmacodynamics. So, pharmacodynamics means mechanism, effects of medicine. Is a drug, is a human being. These are kind of receptors or target molecule. So, pharmacodynamics means what a drug does to the body. And there are two things: action and effect. Action is how and where the effect is produced. Effect is the type of response. So there are few sites or few places where the drug going to elicit its action, like maybe in the cell, extracellular outside the cell, intracellular inside the cell. That means at the nucleus level. So when you given a particular drug, the drug is going to exert its action. So we saw action is drug response. So there are few modes how the drug is going to respond. Either the drug can depress one channel's activity, either it can activate one channel's activity, or the drug can replace a natural ligand, or the drug can produce a local irritation, and sometimes the drug can destroy the cancerous cell. These are the few ways of responses how the drug can elicit its biophysical activity. So the drugs, via these responses, either it going to mimic the effect of the natural mediator, or it going to blocks the effect of the natural mediator. If one drug is going to mimic the natural mediator's effect, we call it agonist. If it is going to block, we call it antagonist. So in pharmacodynamics, we will be going to teach you few terminologies like agonist, antagonist, partial agonist, inverse agonist, competitive antagonist, non-competitive antagonist, irreversible antagonist, and few characters of your drug. Affinity, potency, almost affinity and potency are a kind of similar. Efficacy or intrinsic activity. Okay, so these are the kind of terms we are going to introduce to you. So these are the few examples of agonist and antagonist activity. So then we have known there are things called receptors in our body. Not all the drugs are acting via receptor. All the drugs will go and act on a target molecule. Receptors is one kind of or type of target molecule. Some drugs will go and act on an enzyme. They inhibit that. Like in hypertension, you are taking ACI inhibitor. They goes and bind with the angiotensin converting enzyme and inhibit its action and prevent the conversion or formation of angiotensin 2. So that occasion there is no particular receptor. The drug will act on enzyme. Okay. So there are drug targets. So those target molecules. Those molecules are mainly produced by protein. There are structural targets and regulatory targets. So we'll be mainly focusing on regulatory targets. In that regulatory targets, you will have receptors, ion channels, carrier molecules, and enzymes. We'll be going to look into each of them in detail, but we'll be mainly focusing on the receptors. So what is enzyme? So in the enzyme, a drug will compete with natural substrate for the enzyme. For example, if you take your body at the neuromuscular junction, you will have acetylcholine. Acetylcholine is the natural ligand. In the body, acetylcholine esterase will come and hydrolyze or destroy acetylcholine. But we are giving a drug neostigmine. So neostigmine action is to go and bind with acetylcholine esterase and inhibit its action. That is, neostigmine is going to inhibit acetylcholine hydrolysis. So you need acetylcholine esterase to bind with acetylcholine to do the action. This neostigmine comes and compete with acetylcholine and it goes and bind with acetylcholine esterase. Via neostigmine binding with acetylcholine esterase, it prevents the binding of acetylcholine to acetylcholine esterase. This is competitive inhibition. You have an enzyme that substrate is acetylcholine, but you are giving neostigmine, it comes and bind with the enzyme. So this enzyme cannot act on acetylcholine. That's how you prevent the breakdown of acetylcholine in your body in certain conditions. Okay? Then there are carrier molecules. One of the type of the regulatory protein is carrier molecules. You all know there are antiporter, there are symporter. Antiporter means one ion goes in one way, other ion goes in opposite way. Symporter means both ions goes in same way. There are few drugs comes and bind with these ion channels and initiating the ion flow. Via that, either it can send the molecule inside or it can bring back the molecule outside from the cell. There are other things called regulatory ion channels. The ion channels is another regulatory protein. What these ion channels doing is when a ligand or drug comes and bind with the ion channels, they will open the ion channels for the either inflow or outflow of the ion. When these ions either goes in or comes out, there's a hyperpolarization or depolarization of the particular cell membrane. So there will be a formation of action potential. So either these drugs via binding to the ion channels, then altering the ion movement can suppress or activate the action potential. So these drugs can modulate the action potential. Then the very important regulatory protein is receptor. So here you have to know a few definitions and you should be able to explain what it is. The receptors are responsible for selectively sensing and binding to a ligand. What is selectively? There may be thousands of receptor types or thousands of receptors in your body, but you give a ligand or drug only few particular receptors which are matching for this drug will get activated. That means these drugs, a particular drug will go and activate selectively on a particular type of receptor. That we call selectivity. Once the ligand is bound with the receptor, it forms a response. It will send a signal of transduction and the message is passed. Usually, to elicit a physiological response in your body, the endogenous ligand like acetylcholine, norepinephrine will have to bind with the receptor. Then it will produce a normal physiological response. If a particular drug which we are giving outside binds with the receptor, it will elicit a pharmacological response. As I told you, either the response can be activation, suppression, irritation, and few other two things. So depends on the type of drug you are giving, there may be a good response or there is no response. Usually the agonist drugs will give you a good response. Antagonist drugs will not give any response. Usually, okay? There are complex category inside antagonist. I will explain in next lecture. So now we'll just focus on what is agonist and what is antagonist briefly. Agonist is a drug that possesses both affinity and efficacy. So these terms, affinity and efficacy, we will explain to you. So affinity is, imagine a drug is going and binds with the receptor. Then there is a drug receptor interaction or drug receptor complex formation. The strength of the drug receptor complex is affinity. That means how likely, how much the drug loves or like the receptor. That is affinity. So the more, the stronger the bond after it binds with the receptor. Okay. For a particular drug, imagine, so just imagine we are giving a drug to a person. The drug's activity is to make that person run 100 meters at a stride. So we are giving two kind of drugs. Both are used to make human run faster. But when you give one drug, that person runs 100 meters. When you give another drug, that person only runs 80 meters. So both running of 100 meters and running 80 meters are responses. But when you are running 100 meters, that's more response. So when a drug give the maximum response, we call that maximum efficacy. When a drug helps to run 80 meters, we call still the drug has an efficacy, but it is not maximum. Apply that concept in drug mechanism of action when it comes to efficacy. If a drug can elicit what we are expecting from drug response 100%, that is, that efficacy is high. If the drug is unable to elicit the action or the response 100%, that is only 60 or 70, the efficacy of the drug is low. Okay? I hope now you understand what is affinity and what is efficacy. So for the agonists, they have both affinity and efficacy. Antagonist, there is an affinity. The antagonist drug will go and bind with receptor, but it will not produce any response or effect. So there is no efficacy. So here are a few terminal Affinity, the tendency of a drug to bind to the receptor. I told you how the drug loves receptor and the strength of the binding. The more the strength, the more the affinity. And affinity and potency goes hand in hand. I will tell that later. Efficacy, the ability of a drug to activate the receptor and gives you a response once it bound. So again, they said efficacy. It's a property, it's an inherent property of intrinsic to the agonist that determines how good agonist is. If an intrinsic activity or the efficacy is high, that is 100%, we call that agonist is a full agonist. If that efficacy is not 100, but there is some response, we call that partial agonist. Remember my word, sometimes the partial agonist can act as a competitive antagonist. Then the mechanism of action of drugs. How basically the drugs elicit their action. Either it is receptor mediated or non-receptor mediated. Majority of the drugs. Either they bound with the receptor and then give you the response. Sometimes without binding to any receptor, they give you a response. Like there's a chemical action, there's a physical action. Okay, like when you are giving antacid, it just goes and utilizes the acidic pH in your stomach. If you give proton pump inhibitor, that goes and block your pump. So that is different. And there may be false incorporation, a false ligand can goes and bind with the receptor. And sometimes when you are given vaccine, they form antibody in the body. So this is the non-receptor mediated action. Then we'll come to the receptor mediated action. The drugs produce their effect through interacting with some chemical compartment of living organism or receptor. The receptors are macromolecules, mainly they are protein. They present either on the cell surface or inside the cell in the cytoplasm or in the nucleus. There are three places where you can find different type of receptor. So this is a kind of a receptor. Receptor has two domains. Outside or the outer surface of the cell membrane, it has a ligand binding domain or the drug binding domain. And inside the cell, you will have the effector domain. So one a drug or ligand molecule is recognized by ligand binding domain. There is some conformational changes and then a chemical reaction happens and the response is transported or transducted via the effector domain. Usually, these receptors are, all the receptors are found in our body. So the God prize, the God's ability, there is always normal, naturally finding body's own molecules or natural ligands to bound with those receptors. when we need to modify some action, we need to either activate or suppress that particular receptor. So we are creating drugs which can mimic the structure of the natural ligand. So it goes and acts on the receptor, bind with that, either activate or suppress the responses. Okay. So there is a cell membrane. This is the ligand binding domain. Once this effector domain is inactive, once it ligand binds to this domain, there's a conformational changes and the response is fast. So this is drug receptor complex. Once a drug bound to a receptor, there's a drug receptor complex that gives you the response. I told you what selectivity, affinity, and efficacy. Understand it. Just go through. So there are few chemical bases for drug receptor interaction. That means if you are going to stick a A4 paper on a file cover, we have to use gum. Sometimes we have used normal watery gum. Sometimes if you want to get a very strong attachment, you are going to use that white color sticky jemmy size gum. Sometimes if you want further very strong bond, you may use what the people use in carpentry. There are different type of gel or something. It's very strong. So there are different types of gum available to make the A4 paper stick with the file cover. Like that, so that depends on the type of the gum you use, the strength of the bond differ. Like that, there are different bonds in your body between drug and the receptor. Electrostatic interaction like hydrogen bond, van der Waals, hydrophobic interaction, stereostatic interaction, covalent bonds. The covalent bonds are the least common bonds. So these are different type of chemical basis of drug receptor interaction. Hope you understand. Okay. These bindings are usually reversible. So when you give a drug to the receptor, you give graded concentration little by little, and with that you will get a response. So we are going to plot the response, the drug concentration on x-axis, and the dose response on y-axis, and you will get a dose response curve. Usually the dose response curve is hyperbolic, like that. Can you name or remember a hyperbolic curve you studied or you know? Okay, fine. But hyperbolic curves are very difficult to analyze. Of course, you can analyze, but it's difficult. So what we are going to do is we are going to put our values to semi-logarithm, and you will get a sigmoidal shape curve. When you get a this is a hyperbola, this is sigmoidal. So what is the advantage of a sigmoidal curve is usually the 25 to 75% of the curve, the values will become linear. Here, those are not comes under linear graph. So 25 to 75, it is a linear, so it is very easy to interpret in that range. And 25 to 75 is the kind of median interquartile range or something. So most of the things comes under that area. So it will be easy for interpretation. So the x-axis values convert from arithmetic to logarithmic. So the plotted curve will become sigmoid. Usually between 25 to 75 of the maximal response, the relation between doses and responses will be linear. Therefore, better understanding and better interpretation. See, this is a hyperbola. We converted into logarithmic values of the concentration. Then you will get only the concentration is log. The efficacy, so response is same. So see, the slope is linear in this part, 25 to 75% of the response. So make our interpretation easier, we have converted to logarithmic values. From these curves, you will divide these agonists into full agonist, antagonist, and partial agonist. Full agonists which produce the greatest responses up to a maximum value. That is 100%. I explained. Partial agonists which produce some response but not to a lower maximum value. That means not to the maximum value but a bit lower than the maximum value. That is around 60, 70. Antagonists. These drugs will bind but they will no response on their own. But if you have an agonist, these antagonists will go and interrupt with their drug agonist receptor complex and they will reduce the response of the agonist. So these are the basic idea, full agonist, partial agonist and antagonist. You should be able to define it in your own words if we ask in the exam. Usually they will ask essay. So this agonist, it bonds with the receptor and there's a receptor protein induction and there's a response. Antagonist bound with the receptor, so the agonist will not come and bound to the same receptor at lower concentration, but depends on the type of antagonist. If you increase the concentration of agonist, it will come and bind. Keep that apart, and an antagonist bind with the receptor, occupies the receptor, there will be no response. Agonist. I told you agonist. Agonist has high affinity SL intrinsic activity. Intrinsic activity is what? Efficacy. So these drugs trigger the maximal biological response. The ligand, the drug bound with the receptor fully. So it will gives you the maximal response. Partial agonists, they have full affinity. So it will comes and bound. The strength of the binding is good. The affinity is good. But still it cannot give you the maximum response. So it has a low efficacy or low intrinsic activity. There are things called inverse agonists. They have a good affinity, but they produce an opposite effect. of the agonist. Inverse. Now we are going to look into few terms like affinity and efficacy. Even though I have explained you this, again I am going to emphasize because these terms are very important, because during this fundamental pharmacology, the basic pharmacology, you should understand this thoroughly. So again and again I am going to repeat that. Two fundamental properties of agonist. So these are properties of agonist, that means the drug. Affinity can be defined as the tenacity with which a drug binds to its receptor, the strength or how much the drug loves to bind with the receptor. Efficacy is an inherent property of an agonist that determines its ability to produce an effect. It's an inherent property that determines its ability to produce the response. Efficacy is not the produced response. Efficacy is the inherent property of the agonist that determines its ability to produce response. Okay? It is a property of the drug, not the receptor or tissue. Affinity gets the drug bound to the receptor, and the efficacy determines what happens once the drug is bound. Again, affinity gets the drug bound to the receptor. Efficacy determines what happens once the drug is bound. So affinity and the term potency, they goes hand in hand. Efficacy and intrinsic activity, those terms goes hand in hand. Okay. Affinity. Affinity refers to the strength of the binding between a drug molecule and its target receptor or enzyme. It measures how tightly the drug binds to its target. That means how stronger, how the strength is. Affinity is a property that determines how likely a drug is to bind to its receptor when it's come into contact. When the receptor is there, when your drugs come, and when it's in contact, how much it bounds. Potency. Potency refers to the concentration or dose of a drug required to produce specific response. You have one family of drug, they are going to give you same effect. That you have two beta agonists, they are going to increase the heart rate in the person. So now you are going to, you need to know which one is good, which is more powerful, which is more potent. So to elicit the same effect, that means in a person who's having a heart rate of 60, you are going to increase up to 100. So the both drugs A and B will increase the heart rate up to 100. Now you are going to see what is the dosage of those drugs to increase the heart rate up to 100. So when you have a drug with less dosage, that has high potency, you are getting the same response via the two drugs. One drug, you need less dosage or less concentration. So if you can get a work done with a less amount of drug, that drug has more potential. Okay? It quantifies, not the quality, quantifies the effectiveness of a drug at a given dose or concentration. A drug with high potency will produce a significant effect at a low dose, while a drug with low potency requires a higher dose to achieve the same effect. So the efficacy. Efficacy, also known as intrinsic activity, produced by the drug. A drug with a high efficacy produces a strong. A drug with a low efficacy may produce a weaker response. So far I have taught you affinity, potency, efficacy in a graded manner. I started with small concept and finally end up with comprehensive explanation. Like in the dose response curve, you give drug in a very graded manner. I have put these ideas of basic concept of pharmacodynamics in a very graded manner. Hope you understood those terminologies. So this sorry, dose response curve. When you give a initial dose, the response is slower. But at some point it becomes linear, and once the receptors are saturated, even though you increase the dose of the drug, the effect is a kind of plateau or constant. This is the 50% of the response. So we call it ED50, or this is the percentage of population responding. So that is ED50. If it is the concentration, sorry, the response percentage of the drug, the response, that means it will be EC50, effective concentration 50. So for you, if you can take EC50 and ED50 both for the understanding purposes, that is fine. If you think those are similar, but only for your understanding, that is fine, but those are not similar, they are different. So now I am going to ask you question. You are going to answer me. Okay? So there are three drugs. This is a full agonist. So this is the dose response curve. What is this shape? It is sigmoid shape. Then again a drug B, it has, so for this full agonist, the response is 100. So this is the efficacy, the 100. So efficacy of the full agonist is 100. This is EC50. Concentration, this is the dose concentration. Concentration at which the 50% of the effect is achieved. Okay, this is for the full agonist. Then we again take the drug B, we plotted this again sigmoid shape. But the maximum effect is same like full agonist. So full agonist and drug B has the same efficacy. Even though the maximum efficacy came at higher concentration than this, still it achieved maximum efficacy. So the efficacy of the both the full agonist and the drug B are same. But to get the 50% of the response, the full agonist get with the lower concentration. The drug B need higher concentration than the drug full agonist. So compared to full agonist and drug B, full agonist has the high potency because it gets the response, the 50% of the response at lower dose compared to drug B. So the full agonist has a more potency. So when compared to full agonist and drug B, both has same efficacy, but full agonist has the high potency. Now we will compare between drug B and C. Drug C, even though you increase the concentration, the maximum effect, the efficacy is 50. Here it is 100. So when compared to drug B and C, drug B is more efficacy than drug C. Okay? So that is how you interpret this dose response curve. It is very easy, isn't it? This is the basic idea. So whenever they give more lines or more sigmoid shaped curves in the graph, don't worry. Go by the basics. So if a same efficacy and we have A, B, even imagine E, F, G, H, no need to worry about that. It's the same efficacy drug with the sigmoid shape. The drug comes on your left side. Shifting of the left is have the higher potency because the E50 will achieve that lower concentration. The effective concentration at 50% of the response for A is lower compared to B, C, and D. So the more potency is drug A. The B, C, and D, the efficacy is going down. So the more efficacy is drug B. That means you look at the potency from your leftward shift of the drug. You look for the efficacy in the vertical manner, which is the top that is more efficacious, which going to the bottom become less efficacy. In the same shape of sigmoid, the graph come to the left have more potency. That's very easy to understand. Again, same sigmoid shape, but E50 is achieved at this concentration. Here, 50 here, here, 50 here. So, the drug which has minimal concentration to come to 50% of the response will be more potent. Simple, isn't it? Again, from leftward, the drug become more potent. From top to bottom, the vertical efficacy change. Efficacy differs. This is potency differs. Sideward movement, left side, potency differs. Upward movement, of the graph, efficacy differs. Again, I am again putting this graph because I want you to get the concept very clearly. So any kind of graph, you can work it out. If we ask, what is the potency between drug A, B, C? Can you work out which has the more potency or what is the order? Drug A has more potency. B second. C third. The least potency. The low potency. So what is the efficacy between drug C, D, and E? Can you work out? Drug C, the top has more efficacy. D is having medium efficacy. E is low efficacy. That is how you work out. Okay. Now I am going to give a brief idea about agonist and antagonist. Because what we learned so far, affinity, efficacy, potency, are characteristics of your drug, not the receptor. Agonist and antagonist are another type of the drugs. So they are having that character. Agonists are drugs that bind and activate receptors. Antagonists are drugs that bind to receptors without activating them and consequently prevent the binding of other agonists. The antagonist will come and bind with the receptor. They don't produce any action, but meantime, they will not allow agonist to come and bind. In the lock and key model, agonists are keys that fit into a lock and open them, comes and bind, there is a response. Antagonist, it has the same site for this receptor. It comes and bind, no response. And it will not allow this agonist also to come and bind up to a certain concentration. So the receptors are mainly protein molecules and macromolecules. Agonist possesses both affinity and efficacy. Partial agonists have lower efficacy than the full agonist. Antagonists may act either competitively or non-competitively. Possesses affinity but no efficacy because there is no response. Competitive antagonists bind to the receptor and block the effect of agonists like this. This is the receptor, this antagonist is a competitive one, it will come and bind with the receptor and it blocks the activity of the agonist. But when you have more and more agonists, the more concentration of agonist, it will come and it will dislodge the antagonist and it will give you the response, the same response at higher concentration of the agonist. So that is a kind of competitive. There's a competition to give you the response. There are other things called non-competitive agonists. It binds to a different site. We call it allosteric site, and it still prevent the activation of the receptor. So non-competitive ones are they will not come and attach to the proper receptor. They will come and attach to the allosteric site in the receptor. Via binding to the allosteric site, it will make structural or conformational changes in the receptor. So even though you have a receptor, the ligand cannot come and bind or cannot fit to it clearly. So it cannot elicit a response. In that situation, even though if you increase the concentration of the agonist, you will not get the response. That is the difference between competitive and not competitive. In competitive antagonists, you will get a response if you increase the concentration of the agonist. But in non-competitive, you may not get the response. That is a basic explanation you understand now. In the next lecture, we will going to see in detail of the antagonism mechanism. And different drugs that bind to the same receptor, they may produce same type of response. However, the affinity or the potency or efficacy may be different. Different drugs comes and bind with the same receptor and gives you the same response. But the affinity, efficacy, all can vary. The term potency is used as a comparative term for the distinguishing which agonist has a high affinity for the given receptor. I told you earlier, when there's the same graph, the left side or the drug which can elicit 50% of the effect with low concentration has higher potency compared to other drugs. Potency and affinity goes hand in hand. Efficacy and intrinsic activity goes hand in hand. So when a drug has a high potency, we can imagine it will have higher affinity as well. The drug which can produce an effect at lower drug concentration is more potent. So I told you in the same graph, when the graph moves left side, you will get the more potent one. But all the four are efficacy is equal. The partial agonist. Agonists can also differ in terms of their efficacy or maximum response. A drug that binds to a receptor but produce less than maximal activation are referred as a partial agonist. Here, the dose-response relationship of the four agonists that varies in efficacy. See, there are four agonists, but the efficacy for the A is higher. So what does that mean? The maximum response is varies. That is, efficacy varies. But the EC50 value is almost equipotent for all four. So when the curve is going upward, the efficacy is increases. So again, drug A and B. Compared to drug A and B are both full agonists. A has the more potency. But A and B are both but same efficacy. The partial agonist, it has the less efficacy than the A and B because it is partial agonist. So basically, agonist with the same response ability is going to elicit lower than the maximal response that we call partial agonist. Now we are going to look at receptors and signal transduction. So now we are going to look at the receptor categories. What are the receptor types you are having? Okay. So this is a kind of, if you are taking a beta adrenoceptor agonist, isoprenolone is the more potent, second adrenaline, third noradrenaline when it comes to the beta receptor activity. But the potency for the alpha receptor mediated response for the same three drugs is other way around. Noradrenaline has a high potency, second adrenaline, third isoprenolone. Just know that. Okay. So this is receptor families. From the physiology times, you know this very well. So it's going to be a kind of revision for you all, but we'll go in detail. There are mainly four types of receptor families: ligand-gated ion channels, G-protein coupled receptors, enzymatic receptors, and receptors regulating gene expression. The characteristics of receptor families, again, I made you easy. The ligand-gated are found on the membrane. They affect via ion channels. There is the ligand directly bound to the ion channels and there's a coupling reaction. Example is nicotinic. For the enzymatic one, it's again in the membrane, effect via the enzyme, effect is direct coupling, and example is insulin. So know all these things. It gives you a summary. In the ion channel, agonist ligand comes and bound, made the changes, sodium goes in, activation of the conduction. After changing the action potential here. Then G protein coupled, it is a serpentine receptor, it is a 7 intercrossing, crossing in the cell membrane, and there is a G protein coupled to this receptor. That's why we call it G protein coupled receptor. Okay. So there are three kind of G protein. G S stimulator, G I inhibitor, and G Q the Q cell. Okay. So G stimulatory receptors, there will be a protein activation, G protein, then it forms the second messenger. The formation of second messenger, it is two types. Either it can form cyclic AMP or it can form diacyl glycerol and triphosphate inositol IP3 via the phospholipase pathway. For the cyclic AMP, it activates pyruvate kinase A. Phospholipase, it activates pyruvate kinase C. Those are the differences. And G protein activation, generation of second messenger, then activation of cell signaling. Enzyme type, there's a tyrosine. Insulin is the best, insulin receptor is the best example. Two agonists comes and bind, there's the engulf for internalization, then it phosphorylates the tyrosine on the inner part of the receptor. Then it activates cell signaling. The nuclear ones, they come through, they pass through the cell membrane, it comes and bind with the cytoplasmic receptor, then transport in the nucleus, and it works in DNA level. They transcribe and translate the protein, which are helpful for the new protein synthesis. This is again a summary of that, but it tells you the sign, time. Ion channels are very fast. It will take milliseconds. This is G protein coupled. It will slower. The insulin type enzyme receptors, they will take minutes. This will take seconds. And the nuclear level will take hours to active. But all these are ultimately gives you the cellular effect. So just go through the neurotransmitters. Fast neurotransmitters act via the ion channels. Slow neurotransmitters and hormones for the G protein coupled receptors, like muscarinic receptors, and enzyme linked receptors are insulin receptors and nuclear receptors. In slower method, the ligands bind to their receptors in the cytoplasm. Then this hormone drug receptor complex goes to the nucleus and binds with the specific site of the DNA. It will alter in the gene transcription and protein synthesis. It will take minutes to hours. The ligand gated one, as I told you, acetylcholine both comes and acts, then it allows the sodiums to go in. Then there's a polarization in the cell membrane. So the action potential is formed, then the action is happened. Best example for that is nicotinic cholinergic receptor. Then G protein activated one. This I told you G inhibitory protein. Acetylcholine comes and acts. Then the G protein dislodged from the receptor and it goes and open the potassium channels. Potassium goes out and hyperpolarization. So it will give you a negative effect. It's going to slow your heart rate because these are muscarinic ones. So these are in the G protein effector system, you have adenyl cyclase, cyclic AMP, phospholipase C, inositol triphosphate, and diacyl glycerol, and there's the ion channels for ion influx. So if you take the G protein, there are two well characterized second messenger cascades. One involves G protein, G stimulatory mediated activation of adenyl cyclase that forms cyclic AMP that in turn activate the protein kinase that gives you the cellular effect. Other mechanism is G protein activation of phospholipase C that will break down your phospholipase into inositol triphosphate and diacylglycerol. Diacylglycerol is a second messenger. It stimulates protein kinase C. And the inositol triphosphate stimulates release of calcium from the intracellular store. So it will make you the contraction more powerful. This is G stimulatory, G inhibitory protein. G stimulatory protein via cyclic AMP activate protein kinase A and phosphorylation of the protein. They form cellular response. G inhibitory one, they will inhibit the formation of cyclic AMP. So this pathway is not happen. So it will inhibit the function. It will activate the function. So in the G protein, it is three types. G stimulatory, G inhibitory, and G fuser. So this is again how it acts. The norepinephrine comes and binds with the beta-1 receptor. You have the G stimulatory. So the cyclic AMP is formed. Then you will get protein kinase A. It will give the response. Phospholipase C system. The phospholipase forms diacylglycerol. It activates protein kinase C and it gives inositol triphosphate. It will increase the calcium influx or concentration and activate the phosphorylation of the enzyme. It gives you the response. Again here, example is angiotensin 2 comes and bind and phospholipase C, inositol triphosphate and diacylglycerol. Diacylglycerol is activate protein kinase C. Inositol triphosphate increase intracellular calcium response. The enzymatic receptors, these receptors are directly linked to tyrosine kinase. Best example is insulin receptors. Receptor binding domain present in the extracellular side, other intracellular side, the kinase. It mediates the first step in transduction of signal carried by insulin. These receptors, not only the insulin, there are other kind of factors also following receptor linked cytoplasmic enzyme mechanism. These receptors contain extracellular domain that binds to the specific ligand like insulin and this engulfs and goes inside and activates the protein kinase. The extracellular domain bind to this and the changes happen in the intracellular via tyrosine kinase. The binding of a ligand to receptor produces a change in receptor conformation that allows receptor to interact. The interaction between the receptor causes tyrosine kinase to become active and the activation happens. So this is the again how the gene regulation drugs do the things is very easy to understand. It goes increase the polymerase activity and the transcription, then the translation, then you have new proteins. With that, I think I have gives you the idea of what is a drug comes and act with the target protein. So target proteins are receptor, ion channels, tyrosine enzyme linked one, and nuclear level. So we have looked into mainly receptors and what are the type of receptors. And I have give you few basic concept of drug characters like affinity, efficacy, potency, and intrinsic activity. And I have introduced few terminologies like agonist, full agonist, partial agonist, inverse agonist, antagonist, competitive antagonist, non-competitive antagonist. You should be able to explain each of the term I told you now in your normal language. Okay? They may ask in SEQ question and we expect you to understand those things. If you have any questions, I think you all are brilliant students of mine. You may not have questions. But if you have any questions or doubt, you always feel free to contact me via WhatsApp or email. I always say, may peace be upon you all. Have a nice day, my dear students. Thank you very much.